This is actually a picture of the book signed by Al Roton way back ago, about 10 years ago or so. And, lots of things that I discussed with him at that time, the confusion that I had. He was such a simple anatomist. Everything he made simple. He never made anything complex. And, even if you're trying to ask him difficult question, he'd answer in a very gentle way and very simple way. And I'm really grateful to Atul, obviously, for introducing me, and also to Imad and Bled for doing this day in, day out, every month, nonstop, and all of them wonderful talks. So I'm grateful. Um, well, this is just a coronal schematic section of the cavernous sinus and the pituitary. And we can see this is basic that we teach, what we teach to our residents when they're starting out, that the lateral wall obviously contains the nerves, except for the abducent nerve, which is lying very close to the carotid. And obviously pituitary is lying between the two cavernous sinus, which are extending from one clinoid process to the other, and all the way down to the petrous as well. And you can see that there's diaphragmatic sella covering it, except for where the infundibulum comes out. And the diaphragm sella really is the key to our anatomy in this particular area. Well, I'm going to be talking about basically taking you through how Roton thought the majority of the thing, and in the end, just briefly touch on how we can do this. I know that Ramesh has already talked about the surgical anatomy and surgical aspects, and I understood that the cavernous sinus would be discussed by Sanjeeva, so I'm not touching on those. Sphenoid bone is located in the center of the cranial base. We know this. The olfactory tract, the gyrus rectus, and the posterior part of the frontal lobe rest against the smooth upper surface of the lesser wing. Temporal lobe rests against the inner surface of the greater wing, and pons and mesencephalon lie posterior to the clavicle portion. The optic chiasm lies posterior to the chiasmatic sulcus, and we'll just go through this. So basically, we are seeing the body of the sphenoid, the lesser wing, the greater wing, and we can see the opening, the foramen rotundum, ovale, senior, and the lacerum as well, part of it. We can see the ethmoids in front, and the frontal, and the temporal, and the parietal posteriorly. So this is very important view. When I started out learning neuroanatomy, I think it was very difficult for me to understand this. Now it's become so simple with the 3D anatomy and our cadaver dissection. So greater wings are on both sides, lesser wing are on the top, and the body in the middle. And we have the optic opening in underneath a part of the lesser wing, whereas the superior orbital fissure is seen. At the same time, we have opening of foramen rotundum and the pterygoid canal that's seen as well. The two pterygoid plates are lying median, lateral, inferior to that. And if we see the anterior part, obviously, then we see the foramen rotundum here, the superior orbital fissure, and part of the optics is also seen. And obviously, this is the corpus is seen here, along with the two pterygoid plexus. Again, the ala minor and the ala major lying on both the sides. If you're seeing from the superior aspect of the sphenoid bone, the bone itself, then we can see there is jugum sphenoidale, and then we have obviously tuberculum sella, and the fossa hypophysalis is just behind that, and dorsum sella behind that. Obviously, dorsum sella continues into the two clinoid process posteriorly, whereas the tuberculum sella continues into the anterior clinoid process anteriorly. So, and if you look at an oblique angle, then you can see how from the linguala sphenoidalis, you've got this nice sulcus of carotid. So the whole carotid revolves around, turns around, and swivels its way and going to passing into the cavernous sinus. And from this oblique angle, you can also see the optic canal and part of the superior orbital fissure much clearly on the other side as well. What about the length and the width of the cella? This used to be important when we didn't have measurements scale and we used to measure ourselves. So cellar length normally 17 millimeters, cellar width 15 millimeter. The upper limit of the normal depth is 13 millimeter. The volume is usually calculated by, obviously, it's ellipsoid formula, so volume centimeter cube, which is length into width into depth in millimeters divided by 1,000. So that would give you the answer. And the total volume generally is about 1100 millimeter. So here we are seeing a part of the optics on the right, which are tilted away. And then we can see the whole carotid taking its circle, turning its way. You can see the superior hypophyseal artery supplying part of the anterior lobe here. And at the same time, you can see the basilar on the other side, the carotid itself on the other side going underneath. And these superior hypophyseal arteries, the stalk is important when we are clearing out the pituitary tumor and making sure where exactly the stalk is. If knowing beforehand where exactly the gland is and where exactly the stalk is before surgery in any giant tumor makes life easier for you. And we have shown in a couple of studies that if you know that beforehand, then your outcome of saving the function is much higher. In this particular one, we can see that we have removed part of the dura above, and you can see the sphenoid seen above, the anterior lobe, which is lighter color above, and a posterior lobe below. And we can see the inferior hypophyseal artery turning and going into the posterior lobe itself. The curve of the carotid is seen again in the same way, and obviously this side it's covered. We can see the third cranial nerve going into the roof of the cavernous sinus, and the second and the carotid going underneath the falciform ligament. Pituitary gland, when exposed from above by opening the diaphragm, the superior surface of the posterior lobe of the pituitary gland is lighter in color than the anterior. The anterior lobe wraps around the lower part of the pituitary stalks to form the pars tuberalis, and the posterior lobe we know is softer, it's gelatinous, and more densely adherent to the sellar wall compared to anterior lobe, which is firmer and is easily separated from sellar wall. And we can see that when we are operating in the endoscopy right next to the gland. So you can see that the gland itself, the anterior lobe, turns around, forms the pars tuberalis, and the color difference between the anterior and posterior lobe is very, very obvious. The sphenoid sinus is important for neurosurgeons. I'm sure Ramesh has touched on it. I actually spoke to him last night what he will do and what I will do. So sphenoid sinus separates the cavernous sinus, the cavernous segment of the carotid arteries, the optics, the third, fourth, and sixth, and branches of trigeminal nerve. And we saw that in the schematic diagram that I showed earlier. It separates the pituitary gland from the nasal cavity. It is present as minute cavities at birth, but its main development takes after puberty. So we need to know that if you're a kid, then obviously you'd have very, very small cavities and you'd have a conical type of sphenoid sinus. As age advances, the sinus frequently undergoes further enlargement associated with absorption of its bony walls. The types of sphenoid sinus in the adults depend on the extent to which the sphenoid bone is nematized. We talked about the four types of sphenoid sinus, the conical type in children, which is about 2% in general population. So pre-sellar type, which is in which the air cavity does not penetrate beyond the vertical plane parallel to the anterior sellar wall. And the sellar type, which is the most common, is when the air cavities extend into the body of the sphenoid, but not beyond the sella itself, where when it crosses the level of the sella and goes all the way posterior to the clivus, then it becomes post-sellar. So this is what it looks like. So you can see all the four types, in which obviously depending on how much of nematization and how easy and difficult it is, and especially for kids, you need to plan this beforehand to know where exactly you're going to be drilling if you'd be drilling in that area. Again, it's important for us to know that how the sphenoid sinus is divided by septa, and this is our image guidance. So if the septa is lying in the midline, you know exactly where you're going to be entering. And there is a septa that is going slightly laterally. And then we know that about 1/4 of these go onto the side and be hitting the carotids. And then there are a small portion of these that may be just going and hitting the lateral wall. So these is image guidance for you. So this is for your planning of your surgery once you're inside operating endoscopically. Cavernous sinus, I was just going to touch it shortly. They are located on either side of the sphenoid sinus, sella, and pituitary. They extend from superior orbital fissure in front to the petrous apex behind and surrounds the horizontal portion of the carotid artery. The medial wall of the paired cavernous sinus form the lateral boundary of the sella. So we can see here that the dorsum is seen, pituitary is seen, the tuberculum in front, you have the anterior and the posterior clinoid process is there. And then you can see the oculomotor nerve going through a small cistern, entering into the roof of the cavernous sinus. And basically there's a triangle, oculomotor triangle, that is formed by a line drawn from the anterior to the posterior clinoid, and the oculomotor coming from behind. And you can see the basilar sinus, and obviously this all anatomy is important for us to understand before thinking if you're going to be going into that area. Falciform ligament is actually covering the optics and the carotid, and you've got the third nerve here at the same time, the second nerve here, and entering into the optic canal, and you've got the pituitary and the stalk, and the fourth nerve can be seen on both sides as well. I'm going to be showing the sixth nerve shortly as well. So here, what we have done is that we have taken away the dura covering the part of the cavernous sinus laterally, and at the same time, so what we are seeing is V1, V2, and V3 going there, and the sixth nerve going in through the Dorinos canal underneath. Here we have put in our Watson chain underneath the falciform ligament to show that if the decompression needs to be done anteriorly, how you're going to do that. And obviously for this, you need to be taking the anterior clinoid before you'd be decompressing. So here in this particular part, we have taken half of the covering, the right half, the covering is gone. So you can see the basilar sinus underneath. You can see that the sixth nerve is entering into the Dorilus canal over here, the fourth nerve running up, and at the same time, you have got the cavernous sinus running all the way, in which all these nerves are getting together and then going anteriorly through various foramens and entering into the optics itself. The anterior and posterior cavernous sinus can be seen here as well, along with the basilar sinus. So basically, petrosphenoid ligament covers, which is between petrous and sphenoid, which covers the superior surface of the Dorilus canal through which the sixth nerve is going through. Here in this particular diagram, we can also see that the extension of the basilar sinus on both sides, and also joining with the petrous on both sides as well. Here we can see the anterior clinoid has been removed, and we can see the optic strut just here. You have got the upper and the lower ring of the covering that goes around, and it's really thin. And this basically guides you anytime that you want to be decompressing in that particular area when you're taking out the clinoid. Here we have pushed the trigeminal nerves laterally, and the idea is to see the petrolingual ligament. And you can see that here in this particular diagram, we've got a nerve coming through, which we'll be showing shortly. Here, the sixth nerve, the whole course can be seen, along with fourth nerve also lying in the cavernous. So all of these are going through the cavernous sinus, as you can see from the opposite side as well. So one side is removed, which can clearly show all the exits of the nerves going through into the optics. The branches of the intercavernous portion of the carotid artery that supplies the Sellar are meningohypophyseal trunks, the largest intercavernous branch, which gives rise to inferior hypophyseal artery, and meconal capsular arteries, which are sometimes present or not present. And here we can again see the greater petrosal nerve, at the same time joining together with the plexus around the vessel, and forming into a Vidian nerve. And you can now much clearly see the petrosphenoid ligament as well. At the same time, you can see the inferior hypophyseal artery again turning around from the carotid and supplying the posterior lobe of the pituitary. So the inferior hypophyseal artery arises from the meningohypophyseal trunk and passes medially to the posterior pituitary capsule and lobe, and anastomosis with its mates on the opposite side, and supplies the dura of the sellar floor as well. Meconal capsular arteries are frequently absent, and when present, they arise from the medial side of the carotid and pass to the capsule of the gland. So here in this particular diagram, we can see the meningohypophyseal artery arising and turning around, supplying the posterior lobe. You can see a lingula of the anterior lobe of the pituitary, a small lingula, and you can clearly see the second nerve going through through the optic canal. The location of the nerves in the wall of the cavernous sinus, we have shown in a schematic diagram in here as well, from superior to inferior. third cranial nerve superiorly, trochlear, ophthalmic, and abducent nerves. The abducent nerve, of course, is within the sinus on the medial wall, medial side of the ophthalmic nerve, the optic nerve, and is adherent to the carotid artery medially and the ophthalmic nerve laterally. The intercavernous venous connections are anterior and posterior. We know that, and the anterior one may be divided by either bipolar or by injecting glue into it if you want to be going into the plenum and doing any surgery on the plenum, extended surgeries. So a large venous connection, which we just showed you, is the basilar sinus, which passes posterior to the dorsum sella and upper clivus, connecting the posterior aspect of both cavernous sinus. The basilar sinus is the largest and the most constant intercavernous connection across the midline. The superior and inferior petrosal sinus join the basilar sinus on both sides. The abducent nerve, as we showed earlier as well, often enters the posterior part of the cavernous sinus by passing through the basilar sinus. And this is what we had shown earlier as well. So you've got the intercavernous sinus, the basilar sinus, the inferior hypophyseal artery shown here as well, and our sixth nerve trying to pass through the Dorilus canal after going through the basilar sinus. The diaphragmatic sella forms the roof of the sella turcica, and I had shown this earlier as well. It covers the pituitary gland except for a small central portion in the center, which transmits the pituitary stalk. The diaphragm is more rectangle than circular. It frequently is thin, tenacious structure that would be an adequate barrier for protecting the supracellular structures during transnodal operation. So you have to be careful because really thin and really tenacious structure. So this is where I thought that I talked to Ramesh that I'll take over, and he said that he'll talk about this bit of surgery. So now once we have gone in anteriorly and we have got the ethmoidal perpendicular plate in front, the vomer down here, we can see the sphenoid ostium on both sides. So we are approaching it anteriorly. The sphenoid mucosa is seen as well. You can see the optics above. And once we have taken all that bone away, obviously then we see the clivus, the carotid part, the clival part of the carotid hump we can see here, and we can clearly see the optics anteriorly and the sella itself. And this is exactly what you need to know when we are doing simple pituitary surgeries. Here we have taken out the covering over the pituitary gland, and now you can see that the sinus all around it can be clearly seen as well. Superior hypophyseal artery is coming from the top, and you can see the petrous segment of the carotid here as well very nicely. Obviously, if you want to be going laterally, then you can see the pterygopalatine ganglion as well, and the Vidian nerve on the opposite side as well. Let me just show the brief, let me just take you forward. So this patient had decreased vision for 10 months, just simple removal of keel. This is the tumor patient had. So once you have opened up, taken out the bone, use the Doppler to make sure there's no vessel underneath, open the dura in triangle in the cruciate fashion, and taking out tumor. And then ensuring that we have cleared it out completely over the tumor pituitary gland, which is lying right in front over there. And then we also did this study in which we looked at, along with our friends in Germany, that if you knew where exactly the gland was beforehand, and if you planned it beforehand and you saw the gland at the time of surgery, then the functional outcome is better in those patients compared to others. So it was really my pleasure to give a talk here. I apologize for the delay and the mishap there. Thank you, Imad. Thank you, everybody.